Good evening. Hello. Thanks for joining us. I think those people who are in the waiting room have made it through, so you're very welcome. My name is Louise Halfpenny. I'm the Director of Communications for West Herts Hospitals NHS Trust. And with me, I'm very pleased that I've got Dr. Rachel Hoey, who is the Divisional Director for Emergency Medicine. So tonight's session is a presentation on our proposals, but really focusing in on emergency care. So tonight's session, as with all the others that we've been running, is on Zoom. We ask you to keep your microphone muted and please to keep your camera off, as that just does help us with our bandwidth. And the way that you answer questions is to use the chat function, and please send your questions to West Herts Communications. We are recording the session and it will be posted on our YouTube channel later in the week. And we have had quite a lot of views of those already. So if you've missed any, that is the place to go and catch up. So the aim of this session is to give you an overview of our proposals, and particularly for tonight to provide an insight into how emergency care will change and improve at Watford General Hospital. We will tell you about our engagement programme and make sure that you have an opportunity to ask questions. A little bit of background for you. I know there are quite a few familiar names out there, but I am just going to do a bit of a recap. So we have been working for a long time. People at the Trust for longer than I will tell you it's decades. It certainly is very many years now. We've been trying to secure significant funding for our 3 hospitals, and we've been working with our Commissioner, Herts Valley's Clinical Commissioning Group. In 2019, September, Prime Minister Boris Johnson visited the site, and soon after that he announced that we were part of the Health Infrastructure Plan, which we sometimes call HIP or HIP1 because we're in the first wave. The language has already changed and it's called the New Hospital Programme, and we're one of 8 frontrunners, which we're absolutely delighted about. We feel closer now to securing major investment than we have done for a very long time. However, it's not just as easy as the Prime Minister coming and saying that the money is there, because the money hasn't yet arrived. We've had some enabling money, which will allow us to pay our architects, but beyond that, we have to continue to make a bid for the money that we think we need, and that's called we do that through an outline business case, and we submit that bid to our regulators. You can see them there: NHS England, NHS Improvement, Department of Health and Social Care, and HM Treasury. So you can see we've got quite a lot of people to please, and our application has to be really strong on value for money, and also it has to show that we can deliver by 2025 or soon after. And if you've been to our site, any of our sites, hopefully you've found the care to be really good, excellent in fact, but you've probably not been so impressed by our buildings. So we want to deliver new buildings to you as soon as we possibly can. So your care, your views. For those of you who followed our progress for a number of years, you will be aware that we ran an engagement programme with the CCG called Your Care, Your Future. So the name is similar because it has evolved largely from Your Care, Your Future. It has some of those same principles about providing care closer to home, and also looking at ill health prevention, so how we can keep you well without needing to admit you to hospital. And our proposals are also reflective of national strategies, such as the long-term national plan, and also local strategy. So what we are talking to you tonight has its roots in strategy, and you can read our clinical strategy. That document has a more pragmatic partner, the clinical brief, and that has much more detail about where services will be provided from, looking at our 3 sites. And then there are 2 engagement documents. So we hope within those 4 documents, that suite of documents, you can find something there that matches your level of interest. So the link to our website is there, and we would really encourage you to go and have a look at the documents. So we say three's company, and we know the phrase is two's company, three's a crowd, but actually we think three's company because we're confident that our three hospitals can get along very well. They will complement each other. And what is at the heart of our proposals is really making sure that each site has a more clearly defined purpose. So broadly, that would be for Watford to remain as the site for emergency, specialist and complex care, for St Albans to be the site where we deliver planned surgical care, planned cancer care and an urgent care service, and Hemel Hempstead to be where we provide urgent and planned medical care and care for patients with long-term conditions. So consolidate, not duplicate, is our kind of phrase that really sums up the approach, because over the years, we've probably stretched our services possibly too thinly by wanting to provide lots of them over all three sites. And in speaking to our clinical staff, knowing that we've got this opportunity to change how we work because of the investment, the message has really come back loud and clear that we should think again about how we deliver services, and instead of delivering across three sites, look at where we can deliver from just two or one site. And behind that is the sort of need or the desire for the teams to work together in stronger numbers, and that will really aid training and development. It will produce, or it will be easier for colleagues to get a second opinion if they want to speak to a senior clinician, and it will also help us cover services so that we aren't at risk of cancelling clinics or appointments because of unexpected absence. So we think it really will improve the experience of patients, because our teams will not only be working effectively together, but we intend to make sure that they have the right diagnostic equipment and that that is at the right site to meet the services delivered from that particular hospital. Underpinning all of these changes are digital transformation and also an upgrade to our diagnostic equipment. So we are beginning the rollout of our electronic patient record, which is going to move at pace and really transform the way that we can see information about your health, about the way it can be shared with other organisations with your permission, or that we can see information about your health where you have been treated by other organisations. So it's going to be really, really good in terms of instantly being able to get a picture of you, and also to save asking you the same question many different times when you are a patient with us. As well as that digital transformation, we will also be doing many more appointments online. We were thinking about this before the pandemic, and obviously we've switched many appointments to being online appointments. And the overwhelming feedback is positive. People are enjoying the experience, or particularly enjoying not having to travel to a hospital setting if all they really need is a clinical conversation that they can have over the phone or over an online platform like this. And we are also using apps so that people can upload their health data, which some of that they can measure themselves. So our virtual COVID hospital, those patients, a lot of them have oximeters, which are little devices which help you measure the oxygen count in your blood, and you can send that information through electronically. And that means that the clinical team looking after you can have a really good picture of how you're doing. So we're really looking forward to more digital transformation, but that's not to say that you are compelled to have your appointments in that way. Face-to-face appointments will still be available. So diagnostic equipment is something that we really want to invest in heavily across all of our sites. And as I said, to make it suit the site in particular. So DEXA scanner will be at Hemel Hempstead to help with bone density testing, which is useful for the patients that we expect to see at that site. The MRI and CT facilities at Watford will be 24/7, and the facilities at Hemel Hempstead and St Albans will be there to incorporate the urgent care services that we run from those sites. So the current challenges that we have, as I explained a little bit earlier, are that clinical staff can't always be called on when urgent advice or second opinion is needed because of the way that we've had our teams working across all of our sites. And also there are limited opportunities to consult with colleagues and to provide cover. So that's really something that we think is going to be fixed when we move into this new way of working. So I think I've probably said a lot about the benefits of consolidating services, but we think it will really help with job satisfaction and recruitment and retention, which is really important. And a point there is that we really want our staff to have new and improved spaces to rest and recuperate, which we know from the pandemic is so important. So we think all of these things will be a real morale boost for our current staff, but will also be very good for recruiting new staff. So I'm now going to hand over to Dr. Rachel Hoey. Over to you, Rachel.
Thanks, Louise. Hello there. So I'm Rachel Hoey. I work as a consultant in the emergency department at Watford, and I'm also the divisional director for emergency medicine, which encompasses our urgent and emergency care specialist services across the sites. So to start with, talking about what happens at Watford, our emergency department will actually, of course, be staying at Watford. It's really important that we're able to deliver good, essential, good quality care 24 hours a day. And in order to do that, that has to be on the single site where it's been for some time now. And we're able to provide 16 hours of cover with consultants in the department. And then there's an on-call provision as well. And that's the best way for us moving forward. So part of this redevelopment for us will be about how we make that emergency care floor work for us. Thank you. Okay, so a busy slide, and it talks about all the services at Watford. So as Louise has mentioned, there will be, we've both got emergency care incorporating our specialty colleagues who will come and work with us in the emergency department and the associated assessment units. There's an urgent treatment centre. The department itself is going to be completely overhauled, as you would expect, into a facility with adequate space to see people properly. And within the floor of the emergency care floor, the plan will be to have an emergency department, including the children's department, and also associated assessment areas for people that need a little bit longer to be accommodated and to continue with assessing them through those areas. Working with colleagues in critical care for surgery, orthopaedic colleagues will be next door in a fracture clinic. And in order to facilitate those services, we're building in multidisciplinary team meeting spaces. The car parks there, car parks are very important so that we can get everybody on site, both staff and patients. And so you'll have seen that the multi-storey car park is already started to be built for those people that have been on site. The other specialist services that will be on the Watford site are mentioned there, some neurology and inpatient chemo, and women's and children's, which I think there's a whole separate discussion about, but neonatal care and maternity services will be at Watford. So just focusing a little bit more on what are urgent and emergency care services. So hopefully most of you will be familiar with the term an urgent treatment centre now, and that is something which is a GP-led facility staffed mostly by general practitioners and nurse practitioners, but our training registrars do rotate through that service as well to ensure their training and experience. And then there's this whole area of same-day emergency care, which is a bit of a new thing. The terminology has come out really in the last few years, and it is what it says on the tin. Really, it's about getting patients seen and sorted within a 24-hour period or less than 24 hours on the same day, so that people are not admitted unnecessarily, and with any luck they can have everything dealt with and go home that same day. That's what we're trying to achieve. So how do we deliver same-day emergency care? Well, that's in various places. The emergency department and children's emergency department obviously have always delivered same-day care with patients being discharged. To facilitate people that might need a little bit longer than the 4 hours that we're currently limited to, we have a clinical decision unit attached to the emergency department. And then the other assessment areas that will be all very closely linked together and on the same floor are an emergency assessment unit and an ambulatory facility. And these will provide specialist care for patients with medical conditions, surgical conditions, orthopedics, gynecology, and general surgery. So what this allows is that if somebody attends as an urgent or emergency patient, we've got access to specialty opinion on the same day, and we can communicate with each other about patient care. Thank you. So the Urgent Treatment Centre is what used to be called the sort of minor injury and illness and non-life-threatening conditions. And you'll know that we have an Urgent Treatment Centre already at Watford and Hemel, and these will be remaining on those sites. The minor injury units at St Albans has been closed during the pandemic, and we're still working with colleagues in the CCG as to what the best plan for a facility of urgent care in St Albans is. We're very closely working with them, but I'm unable to tell you exactly what that will be yet. They're still working through their plans. The emergency department is, some of you will have experienced, is split into adults and children. Patients are sorted, if you like, triaged to determine where they're best seen. Some of them will be seen within a main area of the emergency department, and some will be seen, the sicker people, in a resuscitation area, and some might be directly sent from the triaging to colleagues in ambulatory care or the emergency assessment unit, and very swiftly move through into assessment space to be seen by colleagues in other areas. Thank you. The clinical decision unit, now this allows us to look after patients who are considered emergency department type patients for a little bit longer. We see a fair number, and we will continue to see a fair number of elderly patients who we hope to turn around after they've had a physio assessment, for example, after a fall, and they'll be able to go home later that same day, or sometimes if they come in late, they'll go home the next morning. And we have working with physios, OTs and clinical navigator colleagues to get those patients sorted. Sometimes it's a simple thing that somebody is waiting for the results of a scan, and it's going to provide a more comfortable environment for them to wait for the results of any investigations pending. I'd say the emergency assessment unit is very much part of our same-day emergency care package that we're developing as we go, and will house different specialties, and so these patients will be able to be seen in this area, including a frailty assessment unit, which is a service that's been running at Watford for quite some time, but as with many things, it will be a more purpose-built facility for frail elderly people, and they'll be able to have a comprehensive geriatric assessment, which is doctor-led, but also includes, again, physios and occupational therapists. So we'll be able to build something that's really suited to our frail patients within that emergency assessment unit, and for our Surgical colleagues will have suitable treatment spaces. Orthopedic colleagues will be able to do any plastering they require and things like this. And so patients have a little bit longer time to be assessed. Some of those patients will be admitted to hospital, but we really hope that by having all the specialties together with the diagnostics, that as much as possible we'd be able to send patients home from this area on the same day. Thank you. So this same day emergency care, again, it's, as I say, really, I think probably talked about that now. It encompasses any area where we are able to see patients and do all their investigating and treatment on the same day. The ambulatory care unit has been running at Watford for many years. I was a leader as a new service when ambulatory care was just being invented, really. So we will continue to have an ambulant capacity. Now, some of the patients in the emergency assessment unit will also be ambulant, but some of them will be patients that require a trolley or perhaps some monitoring. So the ambulatory care side to this, and we are hoping to make this as flexible a space as possible, will be literally people that are able to walk in to the organisation. So these will be the slightly less acutely unwell patients, and the majority of these patients will absolutely go home. The short stay wards are acute physicians who are the medical consultants who will be looking after medical patients in the assessment unit and ambulatory care. If they need to admit somebody for a period, they will be admitted to the short stay wards, where the length of stay is aimed to be in the region of 48 hours. Thank you. Those of you that look at the NHS plan might be familiar with the long-term plan from 2019, and we've talked about the same-day emergency care aspects of it, but there's more detail within that document. The Urgent Treatment Centre is part of that document as well, and the idea was a rollout of urgent treatment centres across the whole of England, and some places have been a little bit delayed, and ours at Watford, in fact, opened in July 2020, which was a little bit later than the long-term plan hoped for, and that was because of the pandemic. We are hitting these targets, if you like, from the long-term plan, in that we are very actively doing same-day emergency care pathways, which we'll be able to continue to do in our new hospital, and similarly our urgent treatment centre will be up to spec to fulfil this long-term plan from the NHS. Thank you. So we're doing a lot of this stuff already, and you might well say, well, what do you need a new hospital for? Well, so some of you that have been through our emergency department facilities particularly will know the answer to this. The emergency department is housed in one of the oldest buildings on site, was designed for numbers of patients that we were seeing, which were in the region of 50,000, and we're now seeing over 100,000. So the emergency department is really not fit for purpose. In that sense, that the cubicle sizes are quite small. The layout of the department makes it very difficult for the clinicians to see patients easily. There are lots of pillars and walls up, stopping us to have a good view of patients. So that presents a safety aspect for us. So we're in terms of being aware if somebody becomes more unwell, for example. It's really not a great environment for privacy or dignity, and that's something we would really want to improve. And then leading out of the emergency department, what we've done over the years is we've added various structures as we've been given money, but because of the nature of the site, we've only been able to add things into where we have physical space. So it's quite disconnected. So at the moment, our assessment areas are quite a long way away. Our ambulatory care is certainly a long way away from the emergency department. what we really want to do is have a cohesive unit for urgent and emergency assessment of patients, so that their flow from arrival, from some sort of assessment at the front door into the right location, having the diagnostics, and then out, be that home or admitted to a ward, is a sensible flow for that patient, and enables teams to work very closely together, because they'll be on the same floor. I think that's that slide. Thank you. We've been actively involved in conversations with the planners, and it's been an excellent experience and a privilege, because what we're trying to do, and what we'll be given the opportunity to do, is get this right. We are, as clinicians, very much having conversations that allow us, with colleagues, to be able to say, well, you know, this needs to be next to that, and that needs to flow from there, and how are our patients going? If they needed to get from the emergency department, for example, to intensive care, what is their route? What's the way they're going to go? So we've been able to really look at how the urgent and emergency care layout will be. As I said, I think the idea is for this service to be across one floor for most of the service, with just the short stay ward being in a slightly different location. We're working very hard to make sure that we can have great oversight of all our patients, of all groups, and incorporate features that support different patients' needs, so particularly those with mental health issues, learning difficulties, dementia, for our elderly population, making sure that the cubicles are going to be right for them, making sure that the patients and their relatives are able to be in the right location, in a nice environment that for their privacy and dignity as well. We're also working in terms of the routes for adults and children. We've always had a really excellent children's emergency department, and we're very keen to ensure that what makes that an excellent children's emergency department remains as part of the new hospital. And part of that is by making sure that we have separate routes as much as possible for children and adults to come into the building. So I think Louise mentioned this right at the beginning. Some of this is about we want to minimize the different moves that patients have. We've been conscious that patients perhaps feel that they are moved all over the hospital. And so, as I say, by having the single floor for patients needing urgent emergency care, this will be very helpful. We're very conscious, obviously, since the pandemic, about aspects involving infection prevention and control. And so built into our new design will be modern systems in place that will allow us to be able to respond swiftly and effectively to any new threat that comes our way. And we're taking this into account during the building process. Some of this is about having single rooms on site, and there will be some of these within the assessment areas, but not fully. We've talked about a calm and nice environment. We are conscious that the environment at the moment isn't necessarily a calm environment, we're building in light wells, for example, and things that will make the building the soundproofing, which is particularly a problem in the current department, and again focusing on specific age groups requirements, including children's play areas. Was this me or was this Louise?
It was, I think it was you, but I'm happy to
I'm
take
happy
it
to
on,
start.
Rach.
This is my last slide, I think.
Go on then,
Okay.
go for it,
All
go for
right.
it.
So the staff experience, I think people have been kind enough to ask how the staff have been getting on, particularly during the pandemic. And we've been very conscious that as well as our patients having rather out-of-date facilities, our staff in emergency medicine have not had great facilities for rest and relaxation and some quiet time, which is really needed at various points in their day, as you can imagine. So we are absolutely ensuring that we have adequate, suitable staff facilities, some of which will be away from their from the department, and some of them will be quite close to the department as is needed, because people can't leave for a very long time usually. And this includes multidisciplinary team meeting rooms and educational rooms, which is massively important, obviously, to make sure our staff have comfortable environments to learn, to train, and this will make our facility one which people will want to come and work in, of all different disciplines, and our recruitment will benefit from having a new environment for them to be in. Thank you.
Thank you very much, Rachel. So just to wrap up, wanted to mention the engagement plan and our timeline. So you can see that we are heading towards the end of our engagement, our first period of engagement anyway, and with that is the survey, and that closes on the 24th of March. So we finish doing our first period of engagement next week, and then we will look at all the information that we've had, all the feedback that we've had, and that will help us when we plan for our second period of engagement, because it may highlight areas that we haven't been clear enough on, or issues of concern for people. So we will be able to refine the information that we come back out to you with. And our staff are also part of our engagement. So if we have a lot of feedback from our staff, or new or different ideas, then we will feed that in and present that to you. And you will see that the feedback goes towards our board, who will look at it, we think, in the July board meeting. The survey, which I mentioned, has been carried out by a third party. So delivering clinical care is what we hope we can say we're really good at, but devising surveys is not our strong suit. So we've gone to a professional survey compiler who's road tested it before it went live here, and they will also analyse all the results for us, so that there will be impartiality around that. Lots of ways for you to get involved, even though we're coming to the end of our first period of public engagement. If you are a member of a local group or society and you want a presentation, please do get in touch. So email us on the email address there and we can arrange that for you. And please do have a look at the documents that are on the website. And I think the next stage, I don't know if you have the QR code, but if you were to go onto the website, you will see there's a QR code. So there it is. So you can scan that with a phone. So there's really no excuse. So please do give up some time to do the survey. Really useful for us to get your feedback. So now we have questions. I should just say that we are going to finish a little bit before 7 o'clock tonight, and I will prioritise the questions that are in reference to the presentation that we've had from Rachel. Although I'll deal with the first one when you get your breath, Rachel, but I do need to tell you I'm coming to you with a question about how many resuscitation bays. So while you're thinking about that, I will just deal with one question, which is, does this proposal depend on getting 400 million or 590 million? So the proposal that Rachel's been talking about is thinking about a new building on the site, on the land that's adjacent to Watford General Hospital. And so all our plans at the moment are focused on that configuration, that option, and we expect to, or we hope to be able to build up to 90% of buildings new. So it's definitely at the upper end, but we haven't worked out all the costings yet, because between hearing the 400 million and the 590, we've had a pandemic. It's made us think about how we might do things differently in terms of single room layout. Net zero carbon has become more important and wasn't included in those original figures. And there's the cost of the digital transformation. And we are now currently looking very closely at predicted care needs in the local community and bed numbers. So we don't have costs at the moment. We will have them later on in May, but all the things that Rachel has been talking about are part of having a new build on that land that's next to the current Watford General Hospital. So Rachel, the question that I hinted at was, how many resuscitation bays are there now, and how many do you think there would be in the new setting?
Okay, it's curious as to why somebody's asking that question. So I'm going to expand a little, because it's not. So what is important is that we have spent months working out the schedule of accommodation based on a schedule of accommodation in terms of how many of what sort of bays we'd have. So I can assure you that it's been finely calculated. I cannot remember the number of adult ones off the top of my head. It might be 8 and it might be 10. For children, it's 4. But really, it doesn't matter, because what the point is that we have calculated how many resuscitation bays we would need. But what we're going to be doing in the new hospital is that all our majors bays are going to be equipped with monitoring. And what we do at the moment is do a lot of our monitoring within our resuscitation area. So if you remember when I said that we kind of stick buildings on because where we've had space over the years, our resuscitation area has currently 9 beds in. We don't really need 9 beds. Most departments of our size would have about 6, but what we would normally do is step people out of those beds into another bed, but with a monitor. Because we haven't got monitoring in the rest of the department, we don't work like that at the moment. So we've had to base our calculations going forward on what would be a sensible number of resuscitation beds for proper trauma, cardiac arrest kind of things, which is actually often quite a small number, because what you want to do is get those patients sorted quite promptly and then move and step down either into another part of the majors or into EAU. Where we struggle at the moment is our flow out of the resuscitation area, because until recently we had difficulty moving people onto a monitored bed. So I hope that helps. If you really want the exact number, I probably could tell you, but I'd have to check.
Thank you, Rachel. So what you're really saying is that those patients who would need a resus bay can also be cared for in other spaces if necessary.
It's about a differentiation of what is true resuscitation and what is then ongoing care, and having the flow which we're trying to create so that you move people through their pathway. Most people don't need a resus bed for longer than the first hour or so of their stay, but they need to be able to move out.
Thank you. And you said about single rooms. Do you know, again, it's a numbers question, do you know how many rooms would be single rooms within the emergency department?
No, I can't give you a number off the top of my head. Not many in the emergency department, because we need to have observation and access to people. So it's a balance with infection prevention and control requirements and the single rooms. And to be honest, we're not at that granular level of detail yet. We are at the level where we have worked out the number of rooms that we will require, and we've got big blocks that we're putting into the footprint of the new building, and we're moving things around. So although we have an idea of how much space we want, the final picture will depend on on how much we can fit in where, and what our best facilities are for seeing patients. But for example, our mental health rooms will obviously be single rooms and will be absolutely adapted to be safe for our mental health patients, with associated safe bathroom facilities, so ligature free, that sort of thing. Our assessment units will have a higher number of single rooms because patients are in those rooms for longer. But again, in order to accommodate within the footprint that we've got and to have an adequate visualization of patients, we are not putting all single rooms in those spaces, because it wouldn't be the safe way to go.
Thank you. Rachel, can I ask you a question about multidisciplinary teams? And in particular, the question is, will a consultant-led multidisciplinary ED assessment team be used?
So the emergency department is consultant-led, and most of the day, 16 hours of the day, consultant run. And that will be the way moving forward into the new hospital until something like probably 2030, when we might have enough consultant numbers to be 24 hours a day, have a consultant on site. But at the moment we have 16 hours, 7 days a week. I'm not quite clear what the rest of it means in terms of multidisciplinary. So what we would do is work with consultant colleagues, so at all times. So for example, if I had a patient in resus who was particularly unwell and needed to go to intensive care, we would be working with our intensive care consultant colleagues about getting that person to intensive care. If a patient needed a surgical operation, we would be working with a surgical consultant team to do that. So we work in that sense all together all the time currently, and that will continue. But with the emergency assessment unit, those staff that in previous previous times and currently have been going up and down floors, for example, to different wards, will be all on the same ward, all on the same floor. They will work for their shift within that emergency assessment unit, so they'll be very much on hand. So one of our common kind of conditions is if somebody has abdominal pain, particularly young women, and somebody might say, oh, I think it might be gynecological, and then the gynecology people might say, well, I think it might be surgical, and then somebody says it's medical. Those three teams of doctors will be working in that same area, and that will make those conversations a lot easier to have, and the patient will not have to wait as long for those consultations because the staff will be physically present.
So thank you. So from a patient perspective, it will feel like a multidisciplinary team, because you will be seen by the consultant or the clinician most relevant for the condition that you've presented with.
Yeah.
And as you say, they're all going to be on hand, and the benefit of having a bigger assessment area is that can be done. The assessment can be carried out without the patient having to move. So this is a sort of clinicians moving around to be around the patient rather than the patient moving to where they are. Is that right?
Yeah, absolutely right. Thank you.
Okay. I have a question about the Frailty Unit. So I don't know if this is something that you could answer, but it's about input from the social care colleagues. So and I guess that is also part of emergency department as well sometimes, isn't it? Input from mental health colleagues and also social care colleagues. So could you say something about how the boundaries of the department sort of go beyond just trust staff?
Yeah, absolutely. The Frailty team are a particularly good example, but the other team are the Navigator team, who work in the clinical decision unit. And what we are hoping to do in the new build is to have those two areas closer together, because there's a lot of cross skill within Watford. So they're OTs, physios, navigators, and then they also, those staff also spend a lot of time liaising with with, as you say, social care services outside, and they're absolutely all on the same page about sorting out people's people's package of care, getting people into any kind of respite area, and very much the elderly people, even the ones that even some of them aren't necessarily frail, but elderly who come through our department are very much looked after by teams of people that extends absolutely out into the community. So yeah, that's absolutely.
Thank you, Rachel. So I have a question about cardiology that came in. Don't worry, Rachel, I'm not going to throw it at you. I had to phone a friend on this one, so I'm going to do my best to answer this. So the question was, what is the additional cardiology? So on the slide about Watford, where we were talking about bringing new services onto the site, it mentioned additional cardiology. So that is an expansion of our cardiac MRI and CT angiography, and a third catheter lab to allow increased and more complex electrophysiology procedures, and an introduction of percutaneous aortic valve replacement. So you can tell quite obviously that that's not off the top of my head, but that is what I've got from one of our cardiologists, our chief medical officer, in fact. So that's the answer to that question. Expansion of cardiac MRI and CT angiography, third cath lab to allow more complex procedures, and percutaneous aortic valve replacement. So an example of where we are trying to expand, and where possible, this will save patients travelling to London or to other centres, in the same way that we want to bring in some inpatient chemotherapy, interventional radiography, services that are common to DGH pluses, which is a District General Hospital plus, indicating that we are aiming to do more specialist services in addition to the range of services you'd expect from a District General Hospital. Rachel, I have a question about waiting times at the emergency department, and you've explained some ways of working which sound fabulous. Do you think that they will be enough to help us meet the 4-hour targets and for patients to be seen more quickly?
Okay, well, obviously we are always working, and we won't wait for the new hospital to continue to be working to see our patients more quickly. It's something we are on a daily basis, we're trying to deliver. So the other thing to possibly just mention is that there will probably be some changes coming up in terms of the 4-hour target. There are some new metrics that we're expecting to start quite soon, and these are more about the total duration of time that people are in a department. But the bottom line is, yes, we don't want people to wait very long, and we don't want them to be sitting in an emergency department any longer than they have to. And so, yeah, what will absolutely happen is by having a facility to have the space to see people is going to be the critical thing. Sometimes the waiting time is not for lack of a clinician to see somebody, but really physically having nowhere for them to see that person. So by having a flexible space that we can work with in our design, we absolutely trying to ensure that we have enough space to see patients, so that the staff can get things started on people, get people triaged, send them to the right place promptly. We also, of course, are aware that every year we have to consider our workforce, and as the demand for services increases year on year, we do a lot of workforce planning. We've had a recent very successful recruitment and retention strategy for consultants. Our middle grade numbers, our sort of senior doctors that aren't consultants, has gone up recently. So and working with colleagues that run our UTC at Watford has ensured that the staff that they provide to us, they have standards to work to as well, in terms of the time after arrival that they should see patients in. So yeah, the aim is always to see people swiftly.
Thank you. And I have a question about working with Harefield Hospital. And will will there be a change to our working relationship with Harefield Hospital in terms of the kinds of patients that we will see at Watford?
So at the moment, the patients from an ED perspective that we would send to Harefield are those having a heart attack out of normal working hours, because our own catheter lab it doesn't work 24 hours a day. I'm not aware that that's changing, but I might not be the right person just to check that bit with.
Okay, thank you. And can you explain the routes into the emergency department via the UTC? Or this is quite a long question, so that it says, please can you explain the routes into the emergency department via the UTC, ambulance or 111, other than just walking into ED?
Yeah, sure. So we're really trying to promote another government strategy, which is Think 111 First, for patients who do not need an emergency ambulance. So anybody that is able to ring 111 and then make their own way to a facility is part of the Think 111 First strategy. And the idea of this is that patients will call and will be directed to the right place for them. So that might be an urgent treatment centre at Watford or at Hemel. It might be their own GP surgery. It might be a pharmacy. It might be that they need an emergency department. But what we're expecting is that for people that are urgent and not emergency, they will over time stop walking in to the Watford site, actually, and they will be ringing 111 first. The benefits of this is that we can offer them time. It will facilitate the wait that we were just talking about, because what it means is we can plan our services better, we can plan our staffing. Will have criteria to say that if you arrive at a certain time, you have to be seen within half an hour of your appointment time. So those things we're working through now, and that will continue to be the place. If you require a 999 ambulance, or your GP has sent you in by ambulance, those patients will come predominantly directly into the emergency department part of the floor. They will be seen and assessed very promptly by a team of people, which is a multidisciplinary team, a senior clinician, nurse practitioners and our nursing staff. And then we will at that point assess where the best place for that person is to go. Now, some of those patients might be directed to the urgent treatment stream. Some will go into major, some to resus. Some might be appropriate to immediately go around to the emergency assessment unit. So that will be the route for ambulances. And as I said, we are at the moment looking at a drawing which has a separate entrance for paediatric ambulances to the adults, but we're working on that at the moment as to how that might play out. There will, of course, be access for people who do suddenly walk in or are driving somebody in, and because that's inevitably people will continue to do that and not think they've got time perhaps to ring 111. And there are various access points, and the access points from the car park and the ground floor come directly in to the reception area of the emergency floor, and we're looking very much at how those lifts will work and what they will access to make sure that people have got an easy route in to the department. And of course, that will help any relatives who are coming to find somebody if their relative's been brought into the emergency department as well. So we're working. Thanks.
Thank you. Rachel, I've been asked about new services, new units. So you've described very well how a new model of care would be in the new building. Does that enable us to take different kinds of patients? So will it change what we can do for patients? So you've mentioned about the Harefield patients. Is there any change to the model that you haven't explained, do you think?
The same day emergency care work is new and developing, and I suspect that that we will be able to, by the time the new hospital is up and running, we will have more pathways that work on a same-day emergency care model. So again, people might be referred through 111 or through their GP into a particular pathway that will have derived that facilitates their, you know, a booked appointment time and flow through. That will be the area to develop what we can do same day within urgent and emergency care services.
Thank you. And can you describe the difference between the emergency service as you've explained it and a major trauma centre, please?
A major trauma centre is a designated centre to take major trauma. There are several of them nationally. This was a government strategy and again was working on the principles of having your experts in one place rather than some experts in lots of places. So it was about getting your trauma surgeons, trauma anaesthetists, and your trauma intensivists all very much under one roof. And it was a policy that was a few years ago been very successful. And what happens is that if the ambulance crew think that somebody should go to a major trauma centre because of the significance of their injuries, they will go past a hospital like ours, a district general, straight to a major trauma centre. Now, it's worth being aware that trauma is something we do talk about a lot in terms of our planning for Watford General, because we are the busiest trauma unit, it's called, in in the North West Thames Trauma Network. We see many more significant patients who have had significant trauma than other hospitals that feed into our trauma centre, which is St Mary's. And the reason for this is our location. So although we are east of England as a region, it's a long way to Addenbrooke's Hospital, which is the major trauma centre for the east of England region. So we go into London, but it means that our ambulance crews, if they are in the north of the patch, don't go past Watford General straight to St Mary's all the time. Sometimes they do, but quite often they'll come to us because they know we have a lot of experience in trauma. And then we keep some of the trauma at Watford with our specialists, and some of it we then send on after stabilisation to St Mary's.
Thank you very much. And I have one question which I think I can answer, which is about the catch up with the cases on that we haven't been treating during the pandemic. So a lot of our routine surgery was thankfully performed, or at least the most urgent. So we didn't really pause in quite the way that some other hospitals did, at least not with those patients who needed urgent surgery. So we very quickly switched to providing that at another hospital. We work very closely with Aspire at Bushy, but we do still have a backlog of routine surgery that has built up over the time. And the question is whether or not it impinges on our development plans and our timescales. And I haven't heard anyone say that it will, because that is just a matter of making sure that our surgical services are working at maximum efficiency. We've restarted at St Albans. We'll be gearing up as quickly as we can, and we don't think that that will impinge at all, particularly as you've heard, we're talking about developing into a new building. So we will continue running in the current buildings until the new buildings are ready to move into. So that's our approach. So I haven't heard it mentioned anywhere that those two things sort of collide against each other. And the second part of that question was, is this being reviewed in our overall strategy and risk management? And I think the best answer I can give to that is that our risk registers are in the public domain. They're part of our board papers. So for anybody who wants to see how we record risk, it's all there, it's on our website, and we make that public. They're reviewed every month. So all that information is out there if you want to dig into that. And if you are visiting our website, well, I hope the first place you go is the redevelopment area of the website, and that you fill in the survey, because the deadline is coming at us. I did say I would finish just a smidge before 7 o'clock. So I wanted to thank Dr. Rachel Hoey and to thank all of you for joining us. And I hope you can join us for further sessions. Thank you very much, everyone.